In this podcast, we will review the etiology and presentation of post-traumatic elbow contractures. Our objectives will be to cover the causes and pathogenesis of post-traumatic elbow contractures. This will be followed by a brief review of the presentation, physical exam findings, and imaging. As we have seen in previous podcasts, the elbow is a complex joint that has multiple types of motion, including flexion, extension, pronation, and supination. The elbow is important for positioning the hand in space and provides a fulcrum for the forearm to act as a load-carrying joint. Because of these requirements, loss of range of motion of the elbow is poorly tolerated. Normal range of motion of the elbow is from about full extension, or 0 degrees, to 145 degrees of flexion, and 90 degrees each of pronation and supination. Functional range of motion of the elbow is generally from about 30 to 100 degrees and a 100-degree arc of pronation supination to allow use of the hand for daily activities and personal hygiene. However, true functional requirements of the elbow depend on a person's handedness, occupation, hobbies, athletic requirements, etc., and the type and magnitude of the contracture. Its impact on function is therefore highly variable and dependent on all of these factors. The normal elbow capsule reaches maximum capacity at 80 degrees of flexion, where there is the minimal amount of intracapsular pressure and maximum capsular compliance. In comparison, a contracted elbow has only about 40% of the capacity of a normal elbow, secondary to myofibroblast hyperplasia and disorganized collagen deposition. What this means is that not only is elbow contracted and limited in range of motion, but is also altered in its biomechanics, structure, and stability. To see how the elbow normally functions, refer back to Laura's presentation on elbow biomechanics. There are a variety of causes of elbow contractures. The most common cause of acquired contractures is from trauma. A review of 200 patients by Mohar et al. Demonstrated that 38% of a series of patients with elbow contracture had fracture dislocation as the main cause, with another 30% with isolated elbow fractures alone. Trauma can have an immediate effect that results in decreased range of motion, as well as through secondary processes leading to joint incongruity, fragments, malunion, soft tissue contractures, and post-traumatic arthritis, to name a few. Acquired and congenital elbow contractures are less common and may be due to conditions such as cerebral palsy, arthrogryposis, and hemophilia. There are two classification systems used for elbow stiffness. Kay's 5-part classification system is based on the structure impeding elbow range of motion and includes the classes 1 through 5 as listed. This includes soft tissues, ossified soft tissues, fractures, and bony bars. Mori's 3-part system classifies elbow stiffness as extrinsic, intrinsic, or mixed based on the etiology and location. Extrinsic causes are due to structures that are extra-articular and include capsular, ligamentous, and muscle contractures, as well as heterotopic ossification and extra-articular malunions. Intrinsic causes are due to intra-articular structures, including adhesions, loose bodies, osteophytes, and displaced intra-articular fractures and fibrosis. Mixed refers to extrinsic causes that are secondary to primary intrinsic pathology. Although there may be a variety of presentations and complaints depending on the specific cause of the elbow contracture, the most common finding in complaint is a loss of full extension. Patients tend to tolerate a loss of supination less than pronation because the shoulder joint can compensate for a loss of pronation more easily. Because the etiology of post-traumatic contractures is varied, ensure that you take a thorough history to look for any underlying cause, including previous trauma, surgeries, infections, and comorbid conditions, for example hemophilia, which may have led to the contracture. In addition to the usual history, because we've already seen that hobbies, work, and handedness all play a part in overall functional requirements, ensure that you ask about these factors as they can affect future management options. The physical exam should start with a general inspection of the limb to look for evidence of prior injuries, surgical incisions, and skin quality. A detailed neurovascular exam is necessary as function of the peripheral nerves can be affected by preceding trauma, and the function of these nerves, in particular the ulnar nerve, should be documented prior to any surgical intervention. Range of motion should be assessed in flexion, extension, pronation, and supination, ensuring that you compare to the non-injured elbow. Active and passive range of motion should both be assessed, as well as the endpoints of the range of motion. A soft endpoint implies an underlying soft tissue cause, whereas a firm endpoint implies a bony cause. But remember that there may also be a mixed underlying etiology, whereas crepitus within the joint can imply degenerative changes. For a more detailed explanation of other examination maneuvers and special tests for the elbow, please refer back to the previous elbow podcasts. Imaging of the stiff elbow generally starts with plain x-rays, including AP, lateral, and oblique views. Bony blocks and malunions can usually be detected on plain x-rays and give an idea of underlying bony pathology. Additionally, live fluoroscopy can be considered if dynamic studies are required. If a more detailed examination of bony anatomy is required, a CT scan of the elbow will be easy to obtain and provide more information about intra-articular bodies. An MRI is also a good consideration if an underlying soft tissue pathology is suspected. Once the physical exam and imaging have been completed, an underlying diagnosis should hopefully be elicited and can be used to guide management, which will be explored in the next series of podcasts.